Hello and good evening, everyone. I'm so excited you're joining us here tonight. My name is Lena Volland. I'm the Director of Education at the National Hemophilia Foundation. But to frame this a little bit more, aside from my role in the education department, I'm also a physical therapist, and I used to work at a hemophilia treatment center for quite a while. And before I joined the Hemophilia Treatment Center, I actually started out in orthopedic outpatients. And then within that world, I kind of dabbled a lot into chronic pain management. So that gave me a little bit of my starting point here. And that brings us to today's topic here a little bit too, and why I'm so excited of being able to share a little bit of what I've learned throughout the years with all of you tonight. So with this, I have a wonderful person here who is going to help me run the show here tonight, who is Natalia Winberry. So you might see her popping up in the chat there and joining our conversations throughout. So thank you so much, Natalia, for being here. And with this, I would want to get started. So Natalia put it in the chat before too, but we will try to make this presentation a little bit engaging and interactive. So if you can, please grab another device like a phone, or you can also open up another browser window, or you can grab a tablet, whatever you have available. And we will be using a software called Menti. So if we could go to the next slide, please. That would be lovely. So very quick before we dive deeply into this, I'm sure you've seen this slide many times by now, especially if you have shared us throughout the National Education for Empowerment series here. But just to highlight again, our mission is really to be preventing any complications of disorders, as well as really supporting these with research, education, and advocacy. And then most importantly, enabling people with bleeding disorders and their families to thrive. I think that last point there is really the essence and why we are all here today. Next slide, please. So I do want to know a little bit more of where all of you are joining us from tonight, and this gives us a good practice here with the menti.com and with our additional device. So if you can, please go to www.menti.com and use the access code there, which is 10929426. You can also see this at the top of this slide as well. So I can see we have some people here from Oregon. We have somebody here from Georgia. And then I'm actually, even though I'm working for NHF and our headquarters in New York City, I'm actually located on the opposite end of the country. So I live in San Diego in California. Should maybe put that in there too, but they're on the very bottom end of California. That's where I'm located. So yeah, I see somebody else there from the New England area. Oh, I see Kansas City, Kansas. Welcome. I love it. Wonderful. Oh, Metro Vancouver, British Columbia, Canada. Oh my goodness, we don't even have you on there, but thank you so much for joining us. Wonderful. I am so glad all of you are here tonight and share this hour with us. So if we can move on to the next slide, that would be wonderful. Great. So pain is our topic for tonight. So I think it's always important that we kind of define that, like what is it that we are actually really talking about. And there's the International Association for the Study of Pain, which is kind of our big pain board. And what they say pain is, it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I know that reads very funny and it looks as if it's grammatically incorrect, but that is the official definition of what pain is. And what I want to highlight here is we are talking about a sensory and emotional experience. So we really want to keep that in mind. The other part here too is like, when do we define this as chronic? When do we make this shift from acute pain to chronic pain? And we can really say that if we have pain for more than 3 months and that pain is actually negatively impacting our lives, that is when we consider pain to be chronic. If we could go to the next slide, please. Wonderful. So we all know that many people with bleeding disorders do experience pain. And I wanted to put a couple of numbers with this. And it kind of depends a little bit of what studies we are looking at. But when we kind of summarize all of this, we do know that 40 to 70% of people with hemophilia, so we're just looking at hemophilia here, do have chronic pain at some point in their life. We don't have very good numbers on this in people with other bleeding disorders, but it would be pretty ignorant of us to assume that people with other bleeding disorders would not be experiencing pain. We also know that 50 to 70% of people with hemophilia actually do treat their pain with opioids, which is especially important considering our current opioid epidemic, and then also the significant rise during these last almost 2 years of the COVID pandemic as well. We also know that 39% of people with hemophilia say that their pain management is actually insufficient. So while they might be receiving pain management to some sort of a degree, that pain management is actually not really working for them. They are still having a lot of pain. We also know that chronic pain decreases mobility, independence, and our quality of life. And it also increases depression and anxiety in people with hemophilia with chronic pain. We also can make the assumption probably that this is not just happening in people with hemophilia, but in all people with bleeding disorders experiencing chronic pain as well. So just to frame this a little bit of why pain is such an important topic, and I know it gets talked about all the time, but it is really important for our community. So with this, could we please move to the next slide? Wonderful. So when we're thinking about pain and really getting a better understanding of what pain actually truly is, I wanted to give a little bit of a historic perspective because research is such a wonderful and powerful thing, and we are learning more. And as we are learning, our understanding of a topic might actually change. So the same happened actually with pain. So way back when we had the Cartesian dualistic theory, which essentially says that pain is equivalent to the damage we have. The problem is that a lot of people keep thinking that today too, and that is actually not true. We've moved on from this theory. So, but way back when, we really thought whenever there is pain, there's an injury, and the amount of injury is equivalent to the amount of pain we are experiencing, and that is just not true. So from there, we moved on over some other theories into this big new concept of gait control theory. And that is really a pathway of pain signaling, which is regulated at the level of the spinal cord. So this was the very first time also that we acknowledged kind of the contribution of psychosocial factors about other things that are going on in our life. So what the gait control theory really then said is that there are some signals that are being sent from somewhere in our body, and they're coming to the spinal cord, and there they are being regulated. So that kind of holds still true, but now we've really moved on to this current model that we have, which is our neuromatrix model. And the neuromatrix is essentially an array of multiple areas within our nervous system. And all of these areas together kind of assess and interpret the pain information. So this also allows us to really bring in that pain is influenced by our cognitive, emotional, and physical factors. So pain is not just a reaction to a signal. It really is an interpretation of everything that is happening. And what can also happen is that peripheral signals, so signals from outside of the brain, can actually alter how we are interpreting this. And we'll dive a little bit deeper into this. But what the key element here is that pain is an individual experience. And it is really an interpretation of everything that is happening to us. So let's move on to the next slide. So again, what is pain? So, okay, it's sensory, it's emotional, but what is it? So sometimes pain is actually a symptom, and it demonstrates the presence of something else. So sometimes it's really truly a reaction to some sort of tissue damage that happened, right? So for example, you're chopping up some veggies for your dinner and you cut yourself. In that moment, your finger might hurt because you actually truly cut it in that moment. So that is actually sometimes true. And it's helpful for us really when we are thinking about also differential diagnosis. So finding out what is going on in the body with identification of treatment targets. That's very important for us as physical therapists to really hone in. Well, is this a muscle situation? Is it more a joint situation? So it gives us a lot of guidance there. And it also allows us to kind of understand the effectiveness of the treatment that we are providing. Like, is the treatment we're giving you actually decreasing your pain? Is what we're doing actually truly working? So then that's great. So sometimes it's a symptom. Now, the problem with that is think back to that original definition I gave you, where it says it's an unpleasant sensory and emotional experience. So that doesn't fit. And we are again moving a lot into that Cartesian dualistic theory in the beginning. So sometimes it is a symptom, but not always. However, what we can say pain is always, and I really truly mean always, an individualistic experience. My pain is not your pain, and your pain is not Natalia's pain or anybody else's pain. We cannot make assumptions about the experiences that we are making, right? And what we do know is that the mind and the body can't be separated. And we also know that the impact of a person's life and their sense of self will really truly dictate how somebody is experiencing pain. Your pain is real. No matter what anybody tells you, your pain is absolutely real. And you cannot compare your pain to anybody else at all. It is based on the experiences you have made in your life. And you can think back, a good example that I always love to share is I have 3 children. And there was a time in my life where I didn't have these children. So they always ask you this wonderful scale. Who has had the scale? Like from 0 to 10, what is your pain? Everybody heard about that? Everybody been asked that question? I have many times. So my 10 out of 10 before I have given birth to my children was very, very different than my 10 out of 10 now. So I'm not even getting close to a 10 now after having given birth to my children. Maybe my headaches or something else that I'm experiencing is moving up to a 2 or 3. Whereas before I would have screamed and said, oh, 10, 10, 10, 10, 10, right? So it changed, it shifted with my experience, with what I have lived through, what my body has lived through. My body will remember that experience, and the interpretation will be different based on that experience. Now, what is so important about this pain experience lens? Well, it lets us really focus on person-centric care. It is about the individual and what they are going through. And it really allows us to do a better work in shared decision-making by really bringing the patient in as the subject matter expert who can really guide us in their pain experience. So whatever everybody tells you, sometimes pain is a symptom, but pain also is always an individualistic experience, and pain is always real. Next slide, please. Okay, so what that means then also with thinking about this as an individual experience is that we need to employ a little bit more of a biopsychosocial lens. And I absolutely love this quote by Adrian Lowe, who is a wonderful physical therapist who has really done some groundbreaking work in the pain science world. And what he said was, what a patient thinks, feels, and believes about his or her condition will significantly impact their examination, treatment, and prognosis. So what that again means is, again, pain is an individualistic experience, and we can't just narrow it down to a scale from 0 to 10, but we need to put all of the other elements that are driving this patient into consideration. So there's the biological lens, the psychological lens, and the social lens. So let's unpack those a little bit more. And if we can, please move to the next slide. So when we're looking at the bio component, that's really our genetics, any sort of tissue damage that actually truly occurred. So within bleeding disorders, we are often looking here towards hemophilic arthropathy. We're also thinking about like some sort of a system dysfunction, inflammatory processes. We can think here about hormones, diet, sleep, things like that, like really biological components that are upsetting our system. But then we have that psycho component. So that's our thoughts, our beliefs, the meaning that we assign to pain, our emotions, how we are coping with them, and then also our behaviors and what we do through our life. And then we have that social aspect of it. That's our family, friends, our socioeconomic factors, where we live, how we live, environmental context, as well as our culture and society. So we have a difference between cultures of how we are handling pain, how we are coping with pain, what meaning we are associating with pain, and how we're dealing with pain too. So all of that need to come together when we're looking at pain in the assessment as well as the treatment. We cannot look at pain again in a 0 to 10 kind of fashion, but rather need to employ a biopsychosocial lens by bringing all of these factors in, because pain is an individualistic experience. Next slide, please. So I want you to grab your phone again or your other device, or open up your browser. So think about the pain that you have experienced in your life, and it might be related to bleeding disorders, or it might be something else that you have experienced. And think about maybe what is some of the biological, some of the psychological or sociological, factors that might be contributing to your pain. So what are some of the bioelements, some of your thoughts and behaviors, maybe some of the social factors as well that you have given. So you can type those in. Your answers are completely anonymous. You will just see them popping up here. I see environment coming up. Absolutely, where we live. What else? What else have people experienced? So for me, it's also a little bit my family, where, yeah, not enough sleep. Absolutely. For me, it's also my family with how they are acting to pain, or how they are acting towards me. What I ate, absolutely. Absolutely. Here we have some worsening arthritis, chronic disease state. Absolutely. Depression, yes. Those are all interconnected. Wonderful. Thank you so much for sharing. So see, all of these different things can actually impact our pain. It is not just one thing. Disease state, what I ate, we're saying, yes, absolutely. Depressed, depression, absolutely. All of those are connected. So again, think about back that statement that I did in the beginning. We cannot separate our mind from our body. It doesn't, in the chat too, arthritis, previous injury, exactly, that's that biological component. We cannot leave that out. We cannot say like, oh, it's all just happening in your head, right? That's what people always say. No, we still have tissue damage, and that's a driving factor, but it's not all or none. Okay, next slide, please. Wonderful. Thank you so much for everybody for sharing. So again, that brings us to that question still that we haven't fully answered. Thanks so much for sharing. Oh, wonderful. Thank you so much for that comment. Thank you, Teresa. Yes, absolutely. So again, what is that actually pain? So we have this whole looming big definition of sensory and emotional experience. And I keep saying it's an individualistic experience and it's an interpretation of the brain. So let's unpack that a little bit more. So pain is a brain output 100% of the time. So what that means is essentially pain signals or information is being sent from your body through the spinal cord up to the brain. And then the brain is actually processing this information and is interpreting this with all of the other information it is receiving and it has stored. So with this, then it makes a decision, well, is this something A, that needs attention? And B, is this something where we should be sending pain, or should we be sending some other information? So based on that information, it's sending a signal back down, which is the output. So pain ultimately is a protective mechanism. Your brain's main interest is survival. It really wants to stay alive and protect you. So when you're experiencing pain, it is because the brain is thinking there's a threat. There's something that will harm you or hurt you that you need to pay attention to. So it's sending that output of pain there. Now, the problem is that while pain is very often a response to actual potential tissue damage, there is a poor correlation between tissue health and pain experience. So what does that mean? Very often we do have pain when we're having an injury. You might experience a bleed. That is a lot of information that's being sent to the brain. The brain interprets the bleeding situation and will send a lot of pain back down because you really need to protect that area. Probably need to immobilize. It really wants your attention there. But at the same time, as I've said before, there isn't really a good correlation between how healthy your tissue is, or how big the damage is, or how little that damage is, and how much pain you are experiencing. So what you might heard before these stories, somebody is crossing the street and they're spraining their ankle. They're stumbling and they're spraining their ankle really, really bad. But then at the same time, there's a car coming. And that person can just jump up and run across the street and doesn't feel anything. And then a little while later, it is the person is actually starting to feel all the pain in that ankle and all of a sudden can't walk anymore. And then we always say like, oh, there was just all this adrenaline from that very situation, but it's actually an interpretation of your brain. So the brain got all of the information sent up. So your tissue, your nerves were still sending up that information of like, oh, we sprained our ankle and there's all of this madness going on here. But the brain interpreted the other information too and put it in a context like, okay, we have a sprained ankle, but there's a car coming. And I think we're in more trouble if we get hit by the car than with the sprained ankle right now. So it actually gives you a lot of adrenaline. So you're not feeling the pain and you can act and you can run over. And then once you're out of that really dangerous situation, then the brain can say like, okay, we got this under control now. Okay, now let's focus on the ankle and get that situation under control. So that's kind of how the brain is interpreting it. But it always is really input, processing, output. Information of what is happening to the brain. Brain is processing it all, putting it into context, and then an output. Next slide, please. Now, again, context matters here, right? So it's not just that it's putting the present information into context, but it really puts in kind of your past experiences and what you're expecting from the future as well. So what the context truly is, it is the sum of all available information from your internal and external environment. So that does not mean that your injury equals pain or vice versa. Next slide, please. Now, kind of a little bit again on that pain and the different mechanism there that we are dealing with. So we have something that we call nociception. Nociception is pain that is in direct response to tissue damage. So we call that nociception, and that can be mechanical, thermal, or chemical. So that is really that situation, you know, where you're chopping up your veggies and you cut yourself in the finger by accident and you feel that pain there. It's really in response to that injury that you have right there. And the pain is really then localized in that area. It's really there where the damage occurred, and it should be there. So that's nociceptive pain. With bleeding disorders, you often have this when you have a bleeding episode and it hurts right there where it's happening. Now, then we have something called peripheral neuropathic pain or neurogenic pain. So that is pain in response to a damage to a nerve. So a nerve can be damaged or impacted along its entire pathway. And then the pain associated by that will not be directly where the nerve is damaged, but in the area that the nerve is innervating. So nerves have certain areas within the body that they are responsible for. And wherever that area is that the particular nerve is responsible for, that it will be the area that's painful. So for example, in your arm, you might actually be pinching a nerve in your neck, but where you feel it is you feel a tingling in your fingers. Anybody ever experienced that? So the damage is up here, not in your fingers. So then we need to treat that accordingly. And we see that in people with bleeding disorders as well. And then we have this concept of central sensitization. Now, central sensitization often happens with chronic pain. And this is where the little caveat is. So when central sensitization occurs, it is an increased sensitivity of your central nervous system and pain, even though there's no damage occurring. So this is when we're moving into this chronic situation. It doesn't mean that everything is okay and there's no tissue damage at all, but it means that your central nervous system is overreacting. Your brain is over interpreting the information it's being given. So when you think back about the slide we had before, we have that input, processing, and output. Central sensitization is an issue with the processing component. So your brain is making everything way worse than it is and blows everything out of proportion. So that is an issue that's going on that we need to treat a little bit differently than nociceptive pain that is just because of a real injury in that moment, or the peripheral neuropathic pain that's in nerve damage. So central sensitization often happens within chronic pain. And we think that this doesn't happen fast, but they've actually done some really interesting studies where they have found that changes within the brain are happening within minutes of a pain experience, not just within days or weeks or months. It really starts happening fast. So we need to keep that in mind with people who have repetitive bleeding episodes and a lot of hemophilic arthropathy. While the joint damage is still there, there's also a component of that pain experience that is really yielded towards central sensitization, and that requires a little bit of a different treatment approach there. Next slide, please. So just thinking a little bit more about the brain and the plasticity there and what that central sensitization means. So I want to quote Adrian Lowe here again, because I just love this one. It says, "We are all biologically coded and environmentally sculpted." So what he means by that, we are all born with like a blueprint, main blueprint, but that blueprint gets slightly altered by all the experiences we go through, by all the different components we live through. So how that happens in the brain, we have something called a homunculus, which is the picture here on the right side. And this is how our whole body is depicted on the brain a little bit. And when we're experiencing pain, and especially chronic pain and pain over a prolonged period of time, this kind of representation that's normally there gets altered a little bit. Now, what also happens is in the brain with chronic pain, what happens is we're activating parallel pathways, so parallel nerves, and then we're also activating silent nerves, and we might actually forge new pathways within the brain. So our brain becomes plastic and altered based on our experiences that we are making. Now, the problem with that is, especially when we're thinking about pain, is that this wonderful map that is biologically coded gets a little bit smudgy. So like you are having a smudge on a glass where when you're wearing glasses or so, it's not kind of clear. It's getting a little bit fuzzy. Also, some body parts might actually increase in size in their representation. So you have more nerve endings to that. And then you might also have a little bit of a difficulty differentiating between left and right. And we might think that's not the case, but when we're actually testing people in the clinic, it's really becoming fuzzy. So what that means is that chronic pain is actually altering our brain. And that alteration of the brain leads to processing issues when all of the information is being sent from our body up. So that might lead to our brain over interpreting the information it's being sent and overreacting with more pain than we actually should have in that very moment. Next slide, please. So you can think about this a little bit differently too. So does anybody play an instrument? Anybody? Anybody play something like a piano, a guitar, a violin, a flute, a harp, harmonica, the drums, anything? So many people do, and think back a lot. It takes a lot of time to really learn an instrument and to perfect an instrument. So I learned when I was a kid, I learned to play the piano. And I remember in the beginning, I could barely touch just keys and figure out where the keys are. And then after a while, it became second nature. And then I could play much better the more I practiced. So I practiced and practiced and practiced and got better at it and developed my skills. And so we can think about plasticity like that. So changing the brain like that. Oh, somebody played the French horn very briefly. Thanks for sharing, Natalia. we're going to talk about that. So, but think about that. So the brain is actually altering the skill set. So somebody who plays the violin, their touch is changing too, their touch to the strings of how you're feeling them. So the same happened with pain, and the brain is immensely good at learning pain. So when you're having chronic pain and you're having pain for a very long time, your brain is learning more about pain and is getting really good at it, and then assumes that this is normal. Right? So plasticity is really teaching your brain something and altering your brain slightly. Okay, next slide, please. So the other component here, and some people have mentioned this in the very first slide, or at the very beginning, is that there are certain components that are really addressing our pain too, or making our pain worse. And one of them is anxiety and stress. So when we're thinking about how our brain can be altered and how our brain is interpreting pain and is putting everything into context, anxiety and stress can make our pain experience way worse. And the reason for this is this whole system of fight, flight, and freeze. So fight is really when we are often getting angry, we might get irritable and we might get argumentative. In the animal world is when animals start fighting with each other. We also might have this flight situation. And this is when we as humans often try to avoid activities, and we might avoid exercise, sunlight, or maybe we don't even go out to events and share time with family and friends, right? In the animal kingdom, it would be that an animal is running away, trying to run away of that dangerous situation. Or we might get into this freeze mode. Freeze is, for us humans, when we just lay down in bed or on the couch. We can't get up because we're having so much pain. We can't move because we have so much pain. So we're just going to stay in bed. So the problem is that we often spin that in a cycle, and it becomes very fast a vicious cycle. So we might have pain, and then we might experience some additional anxiety, stress, or fear. And then we start to avoid activity. We might start avoiding movement. And that, again, then might increase our anxiety and fear. It might decondition our body, and our brain and our body sensitize even more. And then with that, we're turning that whole pain dial up, and then we're having more pain, and then we're having more anxiety and stress about it. And then we avoid activities even more and decondition our body more. And then our pain gets worse, and we're spinning ourselves around and around and around in a cycle. So we have to break through those cycles. The other thing I wanted to mention here with pain is that if we have high anxiety and stress, it will also increase our cortisol. And that cortisol will weaken our immune system. So that does not help anybody at all. So we have a close connection between anxiety and stress. So very often anxiety and stress can increase our experience of pain. Next slide, please. So with this, you heard me mention the pain dial, and I think that's a very good explanation here. So sometimes we experience things in our life that will just cause that pain dial to be tuned up. And in that very moment, we might actually experiencing more pain than when our pain dial would be down. So for me, that's a lot of stress normally that will increase my pain dial. And then so we need to employ techniques to really dial that pain dial down. Now, when we're having that pain dial up, that's when our brain overinterprets pain a lot. By dialing the pain dial down, we might actually calm the situation down, and the interpretation will be less severe. So the problem is when our pain dial is all the way up, then our body has a really hard time differentiating between hurt and harm. So hurt is that uncomfortable sensation, like when you're going for a run or you're working out and your muscles feel a little bit sore, that's hurt. Harm is when we're actually talking about physical damage, when a muscle might rip, when a tendon might rip, something like that. Now, when the pain dial is all the way up, your brain will misinterpret that information. And very often it will think you're actually becoming harmed. And because of that, it will increase your pain response and your pain experience. So you might have more pain if your dial is up than when your dial is down, even though you're not making any changes in the tissue damage that you might have. Next slide, please. So I want to think with all of you together here, just so I'm not losing you on this topic. Let's be a little bit more engaged here. So grab your devices again, your phone, your other browser. So let's think about what are maybe some things that are making your pain worse? What are some things that are making you dial that pain up? So what are some things in your life that make the pain worse or that increase that dial? So I can share from mine. So one thing that I already mentioned is stress. So when I have a lot of stress, I have like a million of things to do, then I will definitely have more pain. The other thing is, when I have a pile of work, when I have a mountain of work of different things to do, and I just need to kind of work through those really quick, and I feel like I am totally overwhelmed, then the pain is becoming worse. So I love for sharing here. So we have walking, standing makes pain worse. Then when I'm really stressed out, or even when my kid is upset, yes, I have that too. So I told you I have 3 children. So when all hell breaks loose in my house and everybody is just screaming, I'm like, oh my God. That is making me upset too. Yeah, sudden movements that jar an injured area, absolutely. Insomnia, yes, absolutely. Yes, please. Thanks so much, Natalia, for putting that in there. Again, please share. Okay, next slide, please. So there's many different things. So think back about, I was sitting, sorry. So there's many different things that can actually make our pain worse, or pretty much dial that pain up, or put that pain down all the way to the top. So think back to that biopsychosocial lens, or that biopsychosocial model that we often employ to this, to really understand where that is coming from and why you're experiencing more pain. So the other thing that I wanted to bring up here, if we are really employing a biopsychosocial lens and really think from that perspective, how do we actually treat pain? So often it is not done by just treating one element. And very often we make it very easy with just like, okay, here's a pack of pills, just swallow them. It will make your pain go away. But it doesn't treat the complexity of pain. There are many different layers of pain as we try to unpack here. So we need to treat them in a more integrative care approach, and by really employing a biopsychosocial perspective, by treating all of these different areas. And that can truly be carried out by an interdisciplinary team. So we need more than just a physician on there that can prescribe us pain medication, but we need other team members in addition to. So we might need to pull in the physical therapist. We might need to pull in a social worker. We might pull in some outside people. Maybe a pain specialist would be great, but it needs to be done in an interdisciplinary team where we can truly attack all of these different areas. The biological, which is really then the hemophilic arthropathy that people might be experiencing, by addressing any psychological factors. Maybe somebody is having a lot of depression, a lot of anxiety, and then addressing any social issues that are maybe there as well. So we actually have recommended this many, many times. And this is why our hemophilia treatment centers are so well equipped, or have such an array of a beautiful interdisciplinary team. So the NHF McMaster guidelines, they actually recommend an integrated care model. And we don't really have a guideline for other bleeding disorders, but definitely for hemophilia. And that includes all of these wonderful people that can address pain as well. And then we have the MESA guidelines for chronic pain management. So those were published in 2020, and they expand on the CDC opioid prescription guidelines. And they really recommend the addition of a multimodal treatment approach to really, truly get a good handle on pain. So it is not just medication, but it's all of these other elements together. It is not just hemophilic arthropathy, but all of these elements together that need to work. Next slide. So when we're thinking about treatment and how to treat pain, there is not a one size fits all. I wish I could just give everybody a recipe, something easy to follow, and that would work for everyone. But unfortunately, as you've heard now, pain is really complex. It has many, many different layers, and we need to have an individualistic approach to that individualistic experience of pain. So there might be one person who really needs a lot more in the biological department. Maybe there's a lot of hemophilic arthropathy going on that we need to deal with from a more biological standpoint. Maybe we do need to go in and do a surgical procedure, or maybe we do need to go in and do more joint injections and other things, right? But maybe there's a person who also has a lot of social components going on, and we might actually need to hone in much more on those than any of the biological or psychological factors. And we have the same on the other end. Maybe a person is much more driven by their anxiety or depression or other things going on in their life that might overshadow a lot of the biological or social components on here as well. So what we need to do is a very thorough assessment of what is happening in a person to then hone in of what exact treatment is truly needed here so that we can help that person to decrease their pain and to manage their pain to the best of their abilities. It's not a one size fits all. It really is an individualistic treatment approach that can best be done by an interdisciplinary team. Next slide, please. So what I wanted to do now, or where I want to shift now, is things that you can do. So I can tell you a lot about the wonderful team members that you might be able to find at your HTC or out in your community as well. But I really want to bring you in. You are the subject matter expert. You are the one who's living with pain. So what are maybe some things that you can do aside from taking medication or from seeking treatment directly from the treatment center? But what are maybe some things that you can do in your everyday life? So that's where we're going to shift to now. So next slide, please. So one of the things that we talked about is that pain dial, right? That the pain dial often gets really moved high. So what we want to figure out now is a couple of things that we can do to bring that pain dial down so that when we're having painful situations, that we can actually hone in on some of those skills and some of those things that we can employ every day. So one of the questions I actually have for you is, what lifts your mood? What do you do in your life that makes you happy? That really brings your mood up, no matter how low your mood is. Swimming, great. So for me, one thing is, I told you about my children. I have 3 daughters. So when I get to spend quality time with my kids, that for me is amazing. It always makes me happy to just hug them and squeeze them and spend some time with them. It always makes my day. I see some really other fun ones. Fun plans with family and friends. I can de-stress by making sure I get outside. Yes, outside in nature. My dog. I have a dog too. I love my dog. Watching movies, time with friends, the bleeding disorders community. Yes, it warms my heart too. It always makes me happy as well. Time to myself, absolutely. Hiking, music. I see some really awesome comments in the chat here too, helping others. I saw somebody mention prayer. Wonderful. Thank you so much for sharing. So there are many things that make us happy, that lift our mood. So sometimes to dial down that crazy pain, we might want to focus on what makes us happy and try to incorporate that into our day-to-day life. Next slide, please. So another thought here. What are some things that are relaxing your body? What relaxes you? What are some things that you could do that really relax your body? So for me, I haven't shared that yet. I am an equestrian. So I own a horse and I love riding my horse. So when I'm in a lot of pain, I actually love going to the stables and doing a bareback ride on my horse. When I was pregnant with my children, yes, I rode when I was pregnant. I had these moments where I had a lot of pelvic pain, and I would just do these bareback rides on my horse, and it just took all the pain away. I felt so much better afterwards. Here's some other great things: massage, stretching, hot yoga. Yes, I love hot yoga too. Breathing deeply, absolutely. Thanks so much for sharing. So what we can do in that moment when we feel our pain dial is just so high and we're so overreacting, or we're really experiencing a lot of pain, think about what might relax your body. And do you have in that moment an opportunity to do that? A hot bath? Oh yes, absolutely. So do you have maybe a chance to just do a little bit of stretching? Do you have a chance to go for 10 minutes and sit in your hot bath? Or to get a slight little massage? Are there some opportunities that you can build that into your day as well? Next slide, please. So then also, what relaxes your mind? So what really relaxes your mind? For me, one of the big things is meditation. I love to meditate. And I used to absolutely hate it. And then one of my friends told me, well, start out with a minute or two or three, and then you increase it. So ever since then, I've started meditation. It really relaxes my mind. Somebody else mentioned that here too. Thank you so much. Meditation, napping, absolutely, a hot tea. Yes, reading and getting lost in a good book. Oh my goodness. Yes, absolutely. Okay, thanks so much for sharing. So think about this. When your pain dial is all the way up, can you do something that actually relaxes your mind? Could you take a moment to read a couple of pages in that really good book? Prayer, yes, music. Can you say a quick prayer? Can you listen to some music? That will actually help you turn that pain dial back down. Next slide, please. Okay, and what distracts you? What makes your mind just jump off and totally lets you focus on something else? So somebody in this previous slide mentioned a good book. That's it for me. If I read a really good book, a really good article, I can get completely lost and completely forget where I am and where I'm sitting. So that's a wonderful distraction that I always like. But what are some things that distract you? Anybody want to share? You can also type in the chat if you don't want to type in here. That's fine as well. Yeah, good distraction. Yeah, my bad distraction. Noisy neighbor. Yes. Baking a tough recipe. Yes. Noise. Yeah. Baking is a good thing too. That's a good distraction. Okay, great. Thanks so much for sharing. Next slide, please. Good. Now, I'm a physical therapist, so of course I have to bring in physical activity here too. We all know this as well. So the problem is if we are inactive, then we are also entering into a vicious cycle, very similar to that anxiety cycle that I was showing you earlier. So when we have pain, we often like to rest, and sometimes rest is truly needed. So we really got to differentiate there. But the problem is if we're resting too much, then our joints will actually get stiff and our muscles will weaken. Then I will actually move less. I further decline in my fitness level and then increase my weakness. My movement becomes even more difficult, which then gives me more pain. Then I rest more and so forth. And I'm in a vicious cycle. So that often can happen, and we get into this vicious cycle quite fast actually, and then it's really hard to get out of it, and it's really hard to overcome that inertia, right? It's so comfortable on that couch with that wonderful book that you're reading, but sometimes it's really important to move. And we kind of have to make that balance between what are the advantages and disadvantages of making a change or that particular change. And then we need to set goals. And I know that's easier said than done. And they have this way of setting SMART goals. So they need to be specific, measurable, achievable, timely, and realistic. That's all great. But how can we actually overcome that initial inertia? And often it's because our goals are way too high and we can tone them down. So if we go to the next slide, please. So what we know with physical activity that actually works, where we've done some research in bleeding disorders, is we do know it increases our muscle strength and capacity. We do know it increases overall quality of life. It decreases pain reproduction. And we've also found with some great research that aquatic exercises are actually more effective than land exercises for people with bleeding disorders. So that's what the research currently says. However, I need to give that little caveat here that there isn't really a lot of research out there on people with bleeding disorders in this capacity. So we have to pull in some other things too. What we do know though, is that movement is good, as long as it doesn't cause any bleeds, and as long as it doesn't cause us more pain than we already have. So if we can go to next slide. So as I've said, it's hard to start, right? It's very hard to start, especially when we're having pain. So what we need to see is how much can we actually realistically do? And very often we're setting our goals way too high, so they are not becoming achievable for us, and then we just give up. But if we make the goals achievable, then we can actually make it a real change. So one thing that I always suggested to my patients is pacing. So by taking a step-by-step approach, we can actually hone in on a goal that is achievable. So I put a little bit of an example here. So step one is really picking an activity. And I just chose hiking because I love to hike. And in San Diego, there are a lot of really great places to hike. So I love hiking. And my goal would be to hike for 1 hour out of 1 day per week. So that's my big goal. I'm not making it a humongous goal where I'm saying like, oh, I want to hike every day for an hour, because that would be unrealistic. I don't have the time, and probably I wouldn't do it anyways, because I have so many other things to do. So, but hiking for 1 hour, 1 day out of a week, I can do that. Now, step three is, what are actually my abilities? Like, how is it on a day where I have a lot of pain? And how is it on a day where I don't have a lot of pain? Well, I might be able to say that I can hike for maybe 20 minutes on a low pain day. But in all reality, if I have a high pain day, I can maybe do 4 minutes at the most. So then the next step, I kind of average that out, like my high pain day and my low pain day. And then in this instant, with this particular example, that would be giving me about like 12 minutes ish. So then I need to build in a little bit there of a time cushion. So I deduct another 2 minutes just for a cushion there, bringing me down to 10 minutes. And then I want to make sure I take a break too. So I decide to take a 2-minute break in between, half of that. So it's 5 minutes, 2 minutes break, and 5 minutes. So that's my starting point. So I might have that goal of an hour, but I'm breaking this down to what I can actually truly do. And then, Natalia, I'm seeing this on my screen. I don't know if this is on yours too, but I think there's somebody in the waiting room. If you would not mind letting her in, please. So I'm breaking this down to something that I can do in this very instance is hiking for 5 minutes, taking a 2-minute break, and then hiking 5 more minutes. And then every week I might be increasing it. And this might look different for everyone. So, but it gives you a good indication of like, how can you take something that you want to do and really put it within the frame of what you're capable of doing, without overexerting yourself and without increasing your pain, but really helping your body. Next slide, please. Now, another component that everybody can do on a day-to-day basis is mindfulness practice. Now, mindfulness is really a basic human ability to fully present, be aware of where we are and what we're doing, and not overly reactive or overwhelmed by what's going on around us. It's really meaning that we are in the now and in the present, not so much focusing on everything else on our past or what is happening in the future. So as you do mindfulness practices, and there are wonderful opportunities with different apps. One example would be Calm. That's a great app, or Headspace as well, where there's a lot of wonderful mindfulness practices on there. Meditation will also help you get into a more mindfulness practice as well. But before you begin, really check in with your body. Like, do you have any pain? Are you very anxious or stressed? And then start with breathing. And breathing was mentioned before too, but really that diaphragmatic breathing where you're breathing deep into your belly. Scan your body and redirect your thoughts to the present. And then most importantly, be kind to yourself. Then recheck your body. Do you still have pain? What does your pain feel like? And are you anxious or are you stressed? But really starting with focusing on your breathing. And if you can tune out or focus on anything else, just focus on your deep breathing, breathing in and breathing out. And scan your body, and always, always be kind to yourself. Next slide, please. So that brings me to meditation. So meditation really helps us to get into a mindfulness practice. And meditation has really been shown in so many studies in other fields that it is effective and efficacious in decreasing pain and also decreasing anxiety and depression and improving physical health and other health-related qualities of life. But there are no studies in bleeding disorders yet. But we can pull from these other wonderful studies and pull them into our day-to-day practice. So again, some of the wonderful apps that I like to use for meditation include Calm and Headspace. So those are some really wonderful ones that you can have on your phone. And they have short meditations, they have long meditations, but it is something that you can implement into your day-to-day practice to really bring that pain dial back down. Next slide, please. So One more thing before we go, and we have to go through here a little bit quick. So one thing that you can really use to bring your pain dial down again too is, what are some things that you really love to look at? So really thinking about your senses there. So I love to look at the ocean. Old photographs, yes. I love the ocean, the sea. Yeah. So thinking about things that we want to look at. Exactly. Next slide, please. Woods and trees. Absolutely. Now we can also think about what are maybe some things we love to hear. I love hearing crashing waves on the ocean, on the beach. So think about this. You don't have to type it in here, running short on time a little bit, but think about things that you love to hear. Music. Yes, absolutely. Next slide, please. And then think about things that you love to smell. You don't have to type it in, but start thinking about these things that you love to smell. I love the smell of fresh cookies baking, or a pie baking. I love that smell. I also love the smell of the ocean. And I love the smell of candles, chocolates, donuts. Yeah, think about those. Next slide, please. And then what do you love to eat? Do you have some comfort food that you have? I could go for the pie again. I really like a good pie. Ice cream. Yes, absolutely. So think about things that you love to eat. So sometimes really focusing on those can help us bring that pain dial down as well. So have that bowl of mac and cheese. Enjoy it in that moment. It can really bring the pain dial down as well. Next slide, please. And then comforting sensations. What are some things that you love to feel? For me, one of the most comforting things is a hug from my children. Yes, a hug. So sometimes when I have a rough day and my pain dial might be high, I will just go to my kids and hug them and squeeze them. And it will just bring everything back down. A soft blanket. Yeah. So think about those sensations. Think about your senses and the sensations you have to really help you bring the pain dial down. Curling up with a blanket. Yes, absolutely. Next slide. Okay. And then make sure you don't talk negatively to you. So often we get into this pattern, but we really need to make sure we're pulling ourselves out. So catch it, check it, and change it. So we often get into this negative self-talk, and then really think about, what is your thought pattern, and are your thoughts helpful or are they harmful? And check it. Is it true what you're thinking? What happened in the past, and what are you predicting for the future? And then change it, replace it with kind, rational, compassionate messages. So think about back what I said earlier, be kind to yourself, and then think about gray rather than black and white thoughts, and integrate words that make you feel strong and empowered. Think about things that you can do. Think about things that were great today. Think about things that make you feel strong and good about yourself, and replace any negative self-talk with them. I might be having that pain in the knee, but I was able to walk around the block. I might be having that pain in my elbow, but I was able to hug my kids. So it's really bringing in some positivity into this as well. Next slide, please. And then last final thoughts, stay in balance. So to bring that pain dial back down, somebody mentioned before insomnia, really make sure you get enough sleep, you eat healthy, really good balanced meals, plenty of hydration. We get dehydrated so fast. Make sure you're staying hydrated. Make sure to embrace nature and sunshine. You won't imagine how much that can actually change it and turn your dial down when you're actually being outside in nature and see some of the sun. And then balance your time alone with your community. You might have moments where you really need to be alone, and you might have moments where you really want to engage with your community. Balance that out for whatever it is that you need. So stay in balance with all of these. Make sure you're being kind to yourself. Make sure that you are exercising and you're moving about, and make sure you bring in your senses and the things that turn down your pain dial so that you feel empowered of taking care of your own pain experience. And with that, next slide. Very good. That was just a conclusion, a little bit of a summary there for you to read. And the next slide, please. Thank you and questions. Next slide. We'll go through those very quick. You're welcome, Jane. So just a quick thank you to all of our partners here, without whom none of this would be possible. So Credo Biomarin, CSL Behring, Genentech, Hemophilia Alliance, Sanofi, Novo Nordisk, Sangamo, Takeda, and Pfizer. We're so thankful for all of the support that you are giving